I'm proud to introduce Hyman Muss, who's a distinguished clinical scientist at the University of North Carolina School of Medicine, and he directs the Geriatric Oncology program at UNC's Lineberger Comprehensive Cancer Center program. Following his graduation from Downstate in 1968, summa cum laude, Dr. Muss trained in hematology in Boston. He then spent some time on the faculty at Bowman Gray, Wake Forest University, where he rose to full professor. Then he joined the faculty at the University of Vermont College of Medicine before joining UNC School of Medicine in Chapel Hill, where he remains to date. He has had a most distinguished academic career. His overriding interest has been on cancer in older patients, with a major focus on breast cancer in older women. He's committed to caring for older patients, and in interviews, some of which I watched on YouTube, which were fascinating, he describes how much pleasure he derives in working with many of these older patients and hearing their stories. He clearly delights in them. He's published a remarkable 450 papers in peer-reviewed journals, 60 book chapters, and 4 books or monographs. He's led numerous clinical and translational trials and has been lead author on an NCI-sponsored group trial, such as the one that demonstrated the value of chemotherapy in older women with early-stage breast cancer. Along the way, he's been a mentor to numerous students, residents, faculty, and fellows. And I found in a reflective statement that was appended to his CV, he states that he plans to devote yet more time mentoring younger faculty who will lead the next generation of healthcare professionals in caring for our increasing number of older cancer patients. Not surprisingly, he's received many honors and awards in the field of geriatric oncology, but perhaps the most prestigious award that he had was that given for his service in the U.S. Army in Vietnam, for which he was awarded the Bronze Star. Please welcome Dr. Muss.
Well, one, it's great to be back. And to talk to older classmates and a lot of younger classmates. Downstate really gave me great opportunity. So I'm going to talk today about cancer in older people. So I'll give you a little bit of my elevator speech while we're getting ready. So, you know, when I talk to people about cancer and I ask people, what's the average age of cancer in this country? I get numbers like 45. 50. And it's because our media, whenever they do a show on cancer, whether it's Brian's Song or it's any other type of like stand up to cancer, it's all young people. And actually now as we sit here today, the average age of cancer in the United States is 67. 67. And most people who are dying of cancer are in their late 60s and early 70s. And so we really have we really have a tsunami, really, of older patients with cancer. And the problem is, as we get old, you know, Betty Davis really had it right. Old age isn't for sissies. So what's happening to us? So I hate to say it, guys, we're all disintegrating. And this is just looking at things like most of your body functions, whether it's your nerve conduction, and after the last lecture, that's really getting more important to me, cardiac output, renal function, we're all declining dramatically with age. Fortunately, we have a lot of reserve, but we're declining dramatically with age. And this is the incidence curve for cancer in the United States. And the incidence rises dramatically with age. So cancer is a disease of aging. And if you look at colon cancer, if you look at lung cancer, if you look at acute leukemia, every curve looks like this. We don't know why in the 80s and 90s it drops a little. Maybe if you get there, there's something different about you. You have better genes and you don't get as much, or whether it's an artifact of poor reporting or a mixture. But dramatic increases in cancer with increasing age. And then the other thing is our population is aging. So if we look now at cancer prevalence, if you look at the, I don't want to press, oh, I did press the wrong thing. No, there it is. if you look at this curve here, you will see that by the time we get 2040, the vast majority of people, the prevalence of cancer is going to be the purple colored bars, 75 to 84, 85 plus. You're going to see lots of these patients. And what's unique about these patients is they don't just come to your office with cancer. They come frequently with numerous other medical problems. So a great challenge. And unfortunately, older people have really been not put on clinical trials as we've gone through the years. So here's looking at NCI clinical trials, and if you look at the age range, like greater than 75 or even greater than 65, there's a shortage of older patients on cancer trials. So what's happened is a lot of the knowledge that we use to base our treatments on in older people, they really weren't included in the trials. So it's not that we worry, will they respond as well? But what we don't know about is the toxicity. And what's virtually lacking is how does toxicity affect their function as we get older? Their function, their ability to be in the community and live unassisted, et cetera. And we don't have really data from that from clinical trials. Now, I mostly see patients with breast cancer. And breast cancer, there's been marked improvement in mortality rates over the last probably 20 to 30 years, 1 to 2% decrease in mortality rate a year. But if you look at this curve, the vast benefits have been in the younger patients, and this red line here are 75 years and older. So these patients have benefited by improvements in new treatments, perhaps screening mammography, but not as well as younger patients. And what's important here, this is breast cancer specific survival. So this is an overall survival. So if you ever look at a clinical trial and it has a good sample size and the overall survival of the older patients isn't worse than the younger patients, there's something flawed in the data, because there's heart disease and diabetes and all kinds of more increasing prevalent diseases. So this is breast cancer specific survival, and it indicates a lot of the older patients are either not being screened appropriately, or more importantly, they're lowballed as far as modern preventative treatment goes. Adjuvant chemotherapy, endocrine therapy, etc. So the issues are, we know cancer is a disease of aging. We've got a hugely older population that's growing in this country. It's nothing like Japan now, where 29% of their people are 65 and older, and they don't have anybody to take care of them, and they have small families. But we're going to be close to 20% by 2025, and the treatments we have are based on data from younger patients. So what are we going to do about this? So the problem for all of us who are practicing or previously practiced is older age or chronological age is no accurate indication of the health status of an older patient. So if we look here, these are all people in their 70s and 80s, and they're vastly different in their functional status. Got a water skier, we got someone on a walker, etc. Vastly different. So you can't say, when a resident says, hey, Dr. Muss, I'm seeing this 75-year-old woman, it's really not the age that's important. It's their life expectancy and their functional status. So the geriatric oncology iceberg is this. So if you're an oncologist, we're interested in the age of the patient. We have this 50-year-old measure called performance status, which is okay. To get on a trial, you have to be reasonably functional and not highly symptomatic. And then we have your tumor characteristics, and we measure your liver function tests and creatinine, etc. But in older people, that's just a touch of what we do, because below them we have all these other issues of older patients and their polypharmacy, numerous drugs these people come in on, comorbidities, falls, psychosocial problems, functional deficits, sarcopenia, lack of muscle mass. I'll talk a little bit about molecular aging and social support. And we kind of probably all here in this type of group have good social support. But studies have shown that if you live in a place and you have a small apartment in New York City for older people, and no one comes takes you out and you don't have anything to do, you die much earlier than someone whose family comes, takes them out to lunch and to church or whatever they do. So it's very, very important. And we frequently don't know these issues about our patients. So in selecting other treatment, I'm going to show you kind of what people are doing, and your insights will be important here. But it's one to perform a geriatric assessment. And I'm new to this. I'm a faux geriatrician. I learned from the real pros. And then to estimate life expectancy. Because it's not your age, it's your life expectancy, and that's based on a whole host of different factors. And then what's the goal of treatment? Is it to make you live longer, to cure you, to palliate you, or worse? I see some of my oncology colleagues in the crowd, to shrink your tumor by 1 centimeter so you live 3 days longer with terrible side effects. What is the goal of treatment? And then calculate the benefits and risks of treatment. So geriatric assessment usually finds and frequently finds problems we don't find routinely. It finds problems that you can act on. So why do an assessment? Why find out a patient is falling? You know, if you're a gastroenterologist, Larry, why do you want to know? If it's just another piece in these bloated charts we have, well, it's because we've got level 1 evidence that if you send a lot of these people to PTOT or work on them or even fix their cane, we're going to diminish their risk of falls. So it is important, and we can do a lot for them. It allows for accurate life expectancy estimates, and it can predict cancer-related toxicity, and I'll show you some of that. So what is it? And, you know, is this another add-on to already an overburdened group of doctors in America with meaningful use and EMRs? Well, in a way it is. And I've actually got some emails with CMS to see if we can get this reimbursed. Because without reimbursement, you know, I don't think we're going to go very far. So we do a brief geriatric assessment. So I'm talking about oncologists, but this applies to any medical specialty, surgeons, radiation oncologists, cardiologists, because we all have the same issues with older people. So for the health professional side can be done by a nurse or a nurse assistant, is to just get someone to get out of a chair and walk 10 feet and come back. We do a little performance status. This KPS is performance status, which is like 5 categories, like from perfectly healthy person to someone who is up half the day with some symptoms to someone who's quite ill. And then we do this blessed orientation memory concentration. So that's a memory test. And I would ask how many of my friends in this audience, who are all great docs, we had a great education, actually do mini mental status tests as part of their history and physical. I mean, if you look in our charts, you'll never find any. You'll never find any being done. And yet you can have older patients that you've taken history from, they've dressed for you because they're still patients, they're not clients, we're still doctors, we're not providers. So they've answered every question, and they say, hey Mary, what'd you have for lunch? I don't have a clue. And so you really need to ask about people's memory function, and then body mass index, and then we do a lot of self-reported types of questionnaires with the patients. A lot of them need help if they're very sick, but we look at, can you take care of yourself? Can you do instrumental activities of daily living? Can you pay your bills, use the phone, etc.? If you can't do that, you need someone else in your life who can do it, or you can't be by yourself. And then we look at falls, and we look at vision and hearing, and then we do mental health. A lot of older people are depressed or anxious. We frequently don't pick it up. We can intervene and help them. And then social support. So when we find issues, we can get you a social worker. We can, maybe if you're in one of these places and you have no family, we can take you to an aging center twice a week, and you'll have other people and company to do things with, very positive. And then unintentional weight loss. So older people lose a lot of weight. They don't have cancer. They don't eat. They sit in their apartments, they drink tea, they have toast. My mother was a classic example, and they have no joy in eating, and their taste buds are going, and so they lose weight. They don't have usually any exotic diseases. And so things like Meals on Wheels and other support can be very helpful. So we've got this down where we could do this in 10 minutes, And we can do this in 20 to 30 minutes. And now in selected patients in our cancer clinic, we do these assessment. And here's an example. So this is 984 patients. So we're building a database. It's part of a big registry trial in our hospital. And in the yellow, I have the performance status. So these are patients and doctors who agreed that the performance status, this 80 to 100, which is really functional people, is good. So the patient agreed with the doctor on this. And there's a lot of research now in oncology, patient-reported outcomes, where the patients don't always agree with us. And frequently their symptoms and other problems are much more likely to result in problems than we may have assumed. So here is a very healthy group. It's almost 800 patients. And here were the GA identified deficits. Well, there were only 30% of people who had no GA problems. And so they range from 1 to 5. They were all types of problems: mental health, polypharmacy, comorbidities, decreased social activity. These are not picked up in a routine history and physical by the average internist, cardiologist, medical. We don't ask these questions. I do. I ask every resident, does the patient have a dog? And if they can't answer it, they didn't do a good social history. But it's very important to know that, because people with dogs tend to have higher activity levels. And when they tell you they're not walking their dog anymore, that's a bad thing. That's probably worth 50 of these bloated questions that they get on intake. So this was very, very helpful. And then issues related to function, like climbing a flight of stairs, vigorous activity. So these were patients that would have been put on our clinical trials. They're healthy by, quote, the standard history and physical. But there were numerous things that were missed that we could intervene on and do a good job and make their quality of lives improved. So estimating life expectancy. So we have that 75-year-old woman in the clinic, and she's got a breast cancer that's very aggressive in that it's very likely it's going to relapse, and if so, it'll relapse in 5 years, one of these very high-risk breast cancers. So we want to know her life expectancy, because if it's 1 year, we're not going to offer that patient chemotherapy, but if it's 10 years, we will. So there is a wonderful tool on the web called ePrognosis. Anybody ever use this? So a good use of our taxes in this country have been these huge studies that collect data from Americans. So every year you went on this study when you were 50, and every year they collect information, these long questionnaires on your health and your alcohol intake and your meds and your diseases. And they put them into a huge database. And so there are all these databases, but the one I'm showing you here is for community dwelling older people in the United States. Thousands of patients. And what they do is they look at all the variables and they come up with a model here that you can be sitting in the clinic. And so I tell my fellows and residents, I want you to do this with the patient. I want you to calculate their life expectancy. It's a good training tool. And if you look at it, I've got a patient 1 who's very healthy and patient 2 who's not as healthy. And these are the variables in the model. So you would have asked, all of this will be in your chart, right? You know the BMI and smoking history, but frequently the questions here that are actually in these surveys of thousands of patients related to their life expectancy are somewhat different. Like hospitalizations in the last year. You never want to be admitted to an American hospital as an older person. It's like it's going to accelerate. You know what happens? You're in there a week. The nurses today, they're so busy filling out the computer charts that they can't get you out of bed. And then you lay a week, and then we're talking about putting you in a sniff because you can't walk to the bathroom anymore. That's what's kind of happening. So hospitalization, self-rated health. If you have 2 people with an identical medical phenotype, and one of those people says, my health is great, and another says, like my Aunt Rose would have done, oh, I'm so sick, and the person who tells you those things actually are related to your survival. There's actually very good data on this. And then whether they're dependent in activities of daily living or instrumental like bathing. and then difficulty pulling or pulling objects. It was just a question asked, but there are numerous other things you could ask a patient. And if you look at this, so patient 1, this patient who is 75 to 79 has a 4% 5-year mortality here. Now, no one would guess that. No one guesses that because we have a fixed age bias notion, most of us, that this is a really older person. But the class of 1968 knows that we're all very youthful people here, right? Men and women. So, but there is a bias out there. And in fact, for 10-year mortality, if this woman is here with this age group, she's very likely to live 10 more years. 10 more years. So that's important. Patient 2 with a few other problems. She has a 69% 5-year mortality. And if you looked at 10-year, why is that actually not as good? It's because these aren't perfect models, but they're much better than our guesses for these patients. So you can do that. It's all open. All of these are free, and they're very, very good things to deal with older patients. And then what about the goals of treatment? So what are the important outcomes? So if you have a 50-year-old woman with breast cancer or a 60 who's healthy, their outcomes are going to be, I want to live as long as possible. I want to see my kids graduate. I want to do all of this and that. If you get an older patient, their views are frequently different. And you frequently hear, I don't want to be a burden to my family. That is a common scenario. And I want to be as functional as long as possible. So Linda Fried and her colleagues did this wonderful paper in the New England Journal. It should be repeated. And they actually used a question like this: I would rather die than have a treatment that causes and a high burden. So that would be getting chemotherapy. Like for breast cancer, it is a high burden. You're in, there's a lot of side effects. But a lot of people would tolerate it if it really improved their outcomes dramatically. But if there was functional loss or cognitive loss, most people would not accept the therapy. So this is really tough because we have a lot of drugs that cause neuropathy. And in a 50-year-old, a minor neuropathy might not be such a big deal. It might be an annoyance. But in a 75-year-old, it might mean to stumbling and falls and increased other problems. So it's important. And cognitive loss is the scariest thing of all for these older people. And as Lowell and maybe Mike Troner and Marty, who've done work with breast cancer and oncology, will tell you that we were always asked about chemo brain and other things, and we really don't know a lot about the details about this, in spite of a lot of research. So it's a pretty big deal. So what's the goal of treatment? So North Carolina, right? This is it. This is it. And boy, I'd love to be like this, right? I'd like to be like this. So if it's a curable cancer, it's got a meaningful improvement in outcomes. And unfortunately, oncology, marketing, and pharma has been so powerful that they've almost convinced us that if you live 2 months longer, that's really a great thing because it's statistically significant, where the price may be just dramatically high in side effects. So you don't want the treatment to be as bad as the disease. And then for metastatic cancers, virtually all solid tumors, you can't cure them. So you really want to maintain quality of life and function first and not get lost in tumor measurements and other minutiae, which frequently aren't the key issues in the patient. And structured palliative care. We've learned a lot in oncology that high quality palliative care not just improves your quality of life, but in some studies, it's actually improved your survival as much as some of the exciting breakthrough drugs that have been FDA approved. So kind of interesting. And then calculating the benefits and risks of treatment. So this woman made this unfortunate statement. She said, if your time hasn't come yet, not even a doctor can kill you. But she doesn't know modern oncology, right? You got to know this. And so we took the geriatric assessment I've shown you, and there's a wonderful woman named Arthi Haria who's really a worldwide leader in geriatric oncology. And this is a predictive model for chemotoxicity. Grade 3 to 5 toxicity is very substantial. That's bad nausea and vomiting. That's really bad fatigue, very bad stuff. And you can see that there's a lot of, and she took the model, there's a whole bunch of variables in it, but we came down to these variables. And these are 500 patients, some with early and some with advanced cancer, all types of treatment regimens. But you can see what I've circled are things from the geriatric assessment, okay, that we might not think about when we're talking about chemotherapy toxicity, including decreased social activity. And she did all these odds ratio and calculated a score. But nevertheless, this is what she found. She found that you could calculate a risk score, which was pretty nice, a dynamic range here of toxicity, going from the low risk to the high risk patients. And here's our performance status, which is used still in virtually all clinical trials we do. It was worthless, right? It was flat. So things like this are coming about, and we just finished a study, a national collaborative study with 500 women 65 and older with breast cancer, all who got chemo. And we're hoping to refine it down to the different drugs and treatments. But these are things that are happening now that are fun. And in addition, there are models on the web. So I'm just showing you this as an example of how do we calculate the benefit. When you sit down and talk to the patient, what are the benefits? So this is something called triple negative breast cancer, which is a very aggressive form of breast cancer that doesn't express any hormone receptors, estrogen receptor, and also does not have overexpression of a gene called HER2. And these are highly aggressive tumors in growth rate and recurrence. And I just took an example of 2 patients and put them in the model. The numbers are important. What's important is we have reasonably good models there that are better than doctors' guesses. The models are based on clinical trials data. Like if you treated drug A versus drug B, what was the proportional benefit in outcome for drug B compared to A? And you put that in a model and you can calculate the benefits of different treatments. So it's all out there. And together, putting this all data together, you can work with the patient and select treatment. So I'm going to finish with just a few fun things. What about cancer and aging? And what about aging in general? So, the great question is, why do we age? And no one really knows. Why am I not the handsome Paul Newman guy that I was in '68 at Downstate, disintegrating? Don't answer, Larry. So what is happening? So we've been interested, and I learned this from a guy named Ned Sharpless, who's now head of the NCI, a really incredible scientist. And he was interested in genes of aging. So the P16 gene is a gene that encodes for a protein that blocks the cell cycle. It makes cells go into senescent. They don't really die. They just stop dividing. And we've learned that in certain tissues, even though they stop dividing, they can make like bad stuff, like inflammatory cytokines that may affect other organ systems, etc. So we've been interested in measuring this. And as an aside, a lot of the new drugs, so if you watch the Super Bowl, now you get direct-to-consumer Ibrance, $10,000 a month is a Pfizer drug that essentially does the same thing in cancer cells. It blocks the cell cycle. So we've been measuring this, and some great stuff. So I'm not a lab kind of guy, but I schlep the samples into the lab and work with these guys. And so they made these knockout mice where they, as we aged, as these mice aged, what would happen is they put a luciferase gene in. The mice kind of fluoresced, proportional to their aging, proportional to this gene expression. And so you got young mice, and here's what happened. As they got old, they all fluoresced. And it was an indirect measure of the gene. You can look in different organs and things. This is very, very clever research. So we started to look in patients and the public in general. So there are many things. We're constantly barraged on the planet to lots of stuff, ionizing radiation, oxidative stress, and I put chemotherapy there because we're very interested in chemotherapy and aging. But these are all the things that probably change our DNA, and this is a epigenetic effect and cause turn on of these genes to make these proteins. And there's no better example than in children with cancer, right? So we've got these great data on all the kids with cancer we've cured, but the problem is there's a high price in that longevity. So the blue line is children with cancer. Now don't look at the y-axis, it's truncated. it's 80 to 100. But you can see that children with cancer, their survivorship is much less than other people. So a 35-year-old child, a person who's been treated for a childhood cancer has the phenotype of a 65-year-old American now in the United States. So great advances, but high dues. And it's related, these are chemotherapy and radiation therapy patients. And some are second cancers, a lot of heart disease in these patients. We looked at breast cancer patients, and we found out that when we started chemotherapy, we accelerated your genes of aging going up. We measured this in your T cells, in your blood, and we're still doing this work. And in the left panel, the red line going up there are patients who got chemo, and the blue line not. And a lot of this type of research suggests we age people 10 years, even when they're older with chemotherapy. So we are trying to ameliorate this with scalable things like walking, etc., to see if we can do a little bit better. And we're also, a lot of our patients get CAT scans, and we're very interested in muscle mass, because as we get older, if you're not active, you lose your muscle mass. And sarcopenia, loss of muscle mass and strength, is associated with poor outcomes. So here's 2 CAT scans, and there's computerized software. You look through L3, and on the right, you can see all that red muscle there. And on the left, 2 things are happening. Not as much muscle, same BMI, and poorer quality muscle. It's filled by fat. Unlike a good steak, you don't want a lot of fat in your muscles, right? Because it's not good for you. So one of our fellows looked at this and showed that just this skeletal muscle, how much skeletal muscle you had and its quality was really related to your outcomes. And this was all patients who got chemotherapy, early preventive chemotherapy for breast cancer. And you could see hospitalizations, neuropathy. It was a small sample size. So we're very interested in integrating this in a lot of our cancer research studies to see if it's an independent predictive factor of poor outcome, especially in older people. So we have a series of studies now going on, and they kind of all look like this. And this one is like breast cancer. We now have all our patients for early breast cancer that come in go on one of 2 studies. One's for 65 and older, and one is for 64 and younger. And what we do is we give them a chemotherapy, we measure a whole bunch of different variables, and we're doing things like just walking 30 minutes a day, 5 days a week, and using exercise bands to see if we can block the changes in the genes of aging, but more importantly, keep you functionally less fatigued and more able to tolerate your chemo. And this is just an example of the stuff we're measuring, but it's great fun, and it provides a tremendous database for other people to use. Maybe one of the Downstate students can come spend a summer with us doing this. So this is where we are. This is the great team of people that we have in our Geriatric program. We've had great support from the university and also some NCI sponsorship and R01s. And it's really, for me, Downstate was a great opportunity. I'm a Brooklyn boy. It gave me the best possible education. Nobel Prize winners, all the great things we've seen this morning. Teaching me for a diverse group of patients. We did this in the ER, Saturday nights, the drop-offs and all the things that happened. And then allowing me to really make some great lifelong friendships and not putting me in debt. So this was great. And 3 people stand out in my career. One was Ludwig Eichner, who many of us here, he was a chief of medicine when it wasn't a job to raise money, and he was an iconic, wonderful man, wonderful teacher to many of us. And as you know, he went back to medical school and wrote a book and a nice series of articles in the New England Journal, and he just was an inspiring teacher. And the other is Hugh Carroll, who was one of the attendings, just a great guy, and really an iconic Downstate character. And for the life of me, I couldn't find Dr. Paul Dreisen on the web. I couldn't find a photo, but he was a wonderful teacher to me and got me interested in research. So it really was, these are very, very special people. Is he really? Well, you need a picture. You need a picture. It comes up with his phone number, but I can't find him. So, and And just to end the friendship, so I see a lot of my great friends here. So Marty Burke and I roomed together for 3 years. Larry Brandt, great friend. Larry Goodman, Don Wari. We had a really unique group here. Lowell Schnipper, who I still see a lot, and Lowell is doing some great value-based stuff, trying to reduce costs in this country very nobly. And Mike Troner, another oncologist I've kept up over the years. So it's been a great experience, and I have much to thank Downstate for my career. Thank you. Yeah. Today, the world of immunotherapy seems to be on the forefront, and you mentioned about children and the price they pay. I'm sure you're familiar with the program that's going at the University of Pennsylvania for the acute myelodysplastic leukemia success rates. I'm just wondering, where does this not have a place to fit in your overall? So we're learning about older people. The problem with clinical trials is we had a meeting with the FDA. If you look at all the people on these, nivolumab, pembrolizumab, like Jimmy Carter, right? Jimmy Carter's probably the oldest guy ever got treated with that drug. They don't get on the trials. Part of it's doctor bias, because there's no exclusions. When Lowell and I and some of us here started out, they say age, life expectancy, 18 to 65. It's gone, but people tend not to do it. So we don't have all the data, but it seems like older people do reasonably well with these treatments. One of the focus nationally is to look at the toxicity of older people. The FDA is trying to collect all the data it can from some of the trials. We've gone to pharma to do some little carve-out studies in older people. I want to know if these checkpoint inhibitors make you less cause great fatigue in older people, because that's a problem that makes you less able to care for yourself. So we're very interested. I don't think there's probably a great downside, but the research data aren't there, and they are very exciting.
What about CRISPR?
So that's, the Chinese are cloning people now, changing genetic traits in human embryos. For treatment of cancer, we can all think of roles like we're now trying to change DNA and abnormal mutations. So I think it has great potential. I think there are issues. It's not as easy always as it is to modify lots of cells, but I think it's great technology. This is kind of taking individual genes and changing them. Some great stuff. Yeah, Larry.
First of all, that was a great talk.
Thank you.
Thank you. I sort of wanted to take off on Jeff's point. I was not aware that treatment of a young person with chemotherapy, in a sense, accelerates aging, if you will. Right? Certainly diminishes lifespan, accelerates aging. Do you have any information or knowledge about the use of immunosuppressive therapy and biologic agents as we use to treat patients young patients with inflammatory bowel disease? Does this result in any measurable decrease in the parameters you're speaking of?
Not that I know of. Frequently, they're not given alone, so there's always confounding. We may give a biologic with another cancer drug. I am not aware. Lowell, you do a lot of this. Any thoughts? I'm not aware of those drugs.
Biologic agents, as single agents, do have a propensity to facilitate lymphoma.
I'm not talking about secondary.
Right, you're talking about.
I'm talking about function,
Right.
survival.
We don't know, so that's why I love this P16 project. So we've got our pediatric oncologist, St. Jude's is looking at this, looking at pre and post, and we want to look at this. Like, not all chemotherapy drugs accelerate your age. Probably 5-fluorouracil, don't do it. They're anthracyclines, they're cytoxins. So we want to look and collect data on this. But your question's there, and I don't think we know. My bias is probably not going to be overwhelming, but we've been wrong a lot. We need to measure it.
One more question, and then there'll be time to talk during the coffee break.
Okay, hi, thank you so much. I have a colleague, like all of us, he's in his 70s, okay? Internist, was the head medical officer for a pharmaceutical company in New Jersey. He had a pension program that we'd kill for, all right? So, he had some GERD and some reflux, and he was scoped, and, they said, oh, you have, reflux going on. So, coming up on 3 years ago, I went into Lenox Hill, and he had a CAT scan in the ER, and I had the CAT scan, the ER doctor came out and said, you have pancreatic cancer, metastatic to your liver, all right? He's still with us.
Yeah.
And he started out at Columbia, he's at Cornell. His biggest problem, no children, married 40 years, is the caregiver.
Sure.
Okay?
Yeah.
And so his biggest problem now is that his wife of 40 years, she can't take it, she wants to leave. So I'm wondering in the protocols, is there anything built in there to take care of the caregiver?
So that's a great, my wife, who is a retired nurse, has found a new career at UNC Healthcare. As a patient and caregiver support person. And there have been studies looking at the caregiver support, because frequently the caregiver roles change. Like we treat the breast cancer patient, and then a year later the husband gets a terrible cancer. So there are people looking at this. It's a major problem nationally. It's a major problem. We usually get social workers into this. People have done studies, and we know they're stressed and everything. The whole issue is interventions. What interventions work? It's not giving them a brochure on all the problems of caregivers. It's finding out what's specific to them. Do they need someone to come in the house 3 days a week for a few hours so they can get out and do other things? And so people are interested in this, but it's a major issue. And of course, no one wants to pay for any of this kind of stuff.
The amazing thing, he's almost 3 years with
Yeah.
pancreatic cancer, and he's still here.
Yeah.
And that was a diagnosis that 3 months and you're gone.
Yeah, so you never know, and I think it usually doesn't happen. He's very fortunate, but I think it rests you, if you go through this scenario with the patient and you work with them to make the best decision. A lot of people who are, they're going to pick treatment, and that's great. It doesn't always work, and we have stories the other way. We always remember the good things, right? But we have stories the other way where people said, why didn't I ever let Dad take that chemotherapy? But, and that's why I think it is shared decision making. But I think the doc has to put everything on the table if we can get better toxicity estimates. And I think patients will be in a spectrum, and some will do it and a lot won't. As far as your friend, it's great. Love to hear it.
Thank you.